All right. Are you ready?
Yep. Okay. Good morning. I'm Adam Corman, an emergency medicine resident physician at George Washington University with a special interest in catheter placement with the assistance of ultrasound.
Hi, I'm Neal Sikka. I'm a faculty here at GW in emergency medicine, and my area of interest is in healthcare innovation.
And we're proud to present to you SonoStik, a company with the mission of simplifying the use of portable ultrasound.
So the presentation this morning is going to have 4 major portions. We're going to tell you about the Sonostik Solution. We're going to give you some context to the problem we're trying to solve, which is the challenge of placing peripheral IVs assisted by ultrasound. And then we're going to tell you about our value proposition and our team.
So SonoStik began with a case. At George Washington University Hospital, we had a patient come in. They were very sick. We needed to get a catheter in quickly so we could get IV fluids, medications, and help save the patient's life. We helped save the patient's life, but we put the catheter in the wrong vessel. And we did it using the assistance of ultrasound here, which is supposed to help you distinguish between arteries and veins. We went into an artery, and this caused the patient to have their limb lost when the medication went into the wrong place. With that case, and there are many others, 15% of catheters have complications. And so we came up with these new innovations. So the first is an improved catheter and catheter introduction set. The second is a probe cover. And the third is a positioning tool and kit, which then puts everything together.
So let me tell you a little bit about peripheral IVs and placement. Probably everyone in this room has had an IV, if you've had to get any health care. About 150 million patients in the United States get an IV, and that consumes 500 million catheters. Worldwide, that number is about 1 billion catheters. And catheters are used for all sorts of things. They're used for like giving you IV fluids, giving you medications, drawing blood. So there's a variety of reasons that you might get an IV catheter. And there's some interesting facts around IV catheters. One is that the average number of catheters used per successful placement are 2.1. Second is that the first attempt success rate is only 40%. The third is that patients requiring 3 or more attempts are 27% of all patients getting an IV catheter. So that's actually the target market we have here, difficult IV access, and that's how we define it, as requiring 3 or more attempts. Patient satisfaction is low. You can imagine nobody likes to be stuck like a pincushion, especially if you have difficult veins. So 58%. And the average cost for placement of an IV catheter is $70. So there's lots of reasons that a catheter placement might be difficult. Things like patient conditions. So they might be dehydrated. They may have veins that roll. They might be obese. They may have a history of IV drug abuse. So there's a large number of reasons that the access becomes difficult, and you have to try over and over again. And so because it's high failure rate, we've started using ultrasound to assist us and reduce that failure rate because you can actually visualize the vessel. So let me tell you a little bit about the portable ultrasound market. So if you've looked at ultrasounds a long time ago, or if you've had a child and you had an ultrasound done, they're big machines. They usually stay in radiology or stay in the OB/GYN clinic for that purpose. But today they've shrunk down to the size of your cell phone, and you can just attach a probe onto your cell phone and do an ultrasound, and the image quality is really quite good. So this is the SonoSite. It's probably the market leader in portable ultrasound, and has about 80% market share. It's medium-sized, and we'll show you some of that. So the market has grown from 2009 at $450 billion to 2014 expected $530 billion. So it has like a 10 to 15% growth rate, and it's going outside of radiology now. So it's going to emergency medicine, it's going into anesthesia, into critical care. So lots of places where X-ray kind of equipment was always isolated to radiology. Now it's all over the hospital and even outpatient clinics.
So Dr. Sikka and I had these problems with ultrasound catheter placement. We wanted to poll our colleagues to see if they had ideas that would help us with products to improve placement. Were they having the same problems? So we interviewed techs, nurses, residents, and attendings with a sample size of 10, and all of them wanted a kit with all the supplies in it. They also wanted a catheter that put skin markings so that you could place the catheter correctly with the vessel. They found that was a problem. And then 70% thought that visualization of the catheter under ultrasound was important to know if you were an artery or vein after placement. It also took them 5 to 15 minutes just to find the supplies necessary to put the catheter in. So that led us to our first innovation. So here we are. It fits in your pocket. It's a kit with all the things that you need for peripheral IV ultrasound guided line placement. And you can see here all the things that are necessary and why it would take 5 to 15 minutes just to get it together. So you flip it over, and here it is. It's a positional tool also, so it can align the arm for IV placement and is more comfortable for the patient if you've ever had to have an IV placed. This is it has a cushion and allows that to happen. Our next product here is an ultrasound probe cover. You can see that smaller, it goes just on the end. And this is the only accessory that we have competing with us in the ultrasound IV market. And it's a cover here. You can see it comes in a kit, and it's super long. It's hard to put on, and it's never used for peripheral IV line placement because it's so difficult. And then next we have the catheter introduction set. So here you have two different types of introduction sets. So this is all about introducing the catheter into the skin. So here's the catheter at the end. You can see it's plastic. This cannot be visualized well with ultrasound. And you have a needle that can be visualized with ultrasound, so you follow the needle tip and hope that your catheter goes in the right spot. Afterwards, you don't know. That's traditional. This is a little bit more advanced. It has a guide wire here. So you place the guide wire, and then you put the catheter over it, and that goes into the vessel. And so you can visualize the guide wire, you can visualize the needle, but then afterwards you can't see the catheter. And I have to place this, so it usually takes 30 minutes to place an IV with traditional methods, so we'll see how it goes. Okay. You flip the screen, so then here is an...
So you can see that he found the vessel, which is actually this image right here, and it's empty. And now he's going to put the needle into the vein. And when the needle goes into the vein, you can see the artifact showing up over here, the white mark. So now you know you're in the vessel. And now he's got a problem because he wants to thread the guide wire in, but he only has two hands. So he can either grow another arm, or he can find me, or find someone else to come help him. So I'll have to hold the ultrasound, and then he could advance the guide wire and then advance the catheter. So that's where the next innovation comes from, and that is a mechanism here for us to advance the guide wire in just using one hand. So now he can continue to keep his left hand on the ultrasound and advance the guide wire in with his right hand.
So we can see we're in place, but then when we're trying to figure out where the catheter is, it's difficult to see that it's in there or not.
So this image is actually of the catheter in place, but it looks exactly like this image. So once the catheter's in place, you can't see where the catheter is.
So we could be an artery or a vein. It's difficult to tell, especially in sick patients. That's very hard to tell. The blood in arteries look like the same in veins. In very sick patients, sometimes it can be different. So, you can see the blood coming out.
So basically what we decided to do was to figure out a way that we could coat catheters so they could be visualized under ultrasound. Various materials have different properties that change impedance on ultrasound, and there's lots of different mechanisms that you can use to then coat those catheters. So that gives SonoStik a really large marketplace because it doesn't only affect the peripheral IV catheters, but it can affect central venous catheters and even catheters. All sorts of catheters, Foley catheters need to be visualized under ultrasound and sometimes can be difficult to see. And if they are coated with this, then they could be visualized as well. So we believe the SonoStik kit actually has a benefit to all the players in the healthcare system. That does include the doctor, the hospital, and the patient. So first, you can see if you accumulate all the supplies, you can save time. If you have the right tools, with the right technology, you can obviously save time. This is actually a billable procedure for doctors. If the doctor places the IV, there's a CPT code that allows an ultrasound-guided IV to bill at $121. So a new revenue source. It reduces complications. From the hospital's perspective, you can improve patient satisfaction because they're not struggling to get IVs in. You can use this equipment for even the non-difficult IV so that they're more comfortable. You increase efficiency, reduce infection rates using a probe cover more frequently, and you reduce the cost in a bundled payment system where you're only reimbursed for that one diagnosis or one disease. And so if you can decrease personnel time, decrease supplies time, you now have a larger margin in taking care of that patient. From a patient's perspective, you reduce complications, you can reduce pain, you can get care to them faster because you're not struggling to try attempting 3 times before you get the IV catheter in. And actually you can reduce radiation exposure because when you place an IV catheter and you can visualize it under ultrasound, you could save x-rays, and that reduces exposure. So some of the numbers, using ultrasound in the SonoStik applications, we think we can reduce the number of catheters used by patients by 50%, the time to placement from 30 to 15 minutes, so also by 50%, and the overall cost of an IV placement. So all those accumulate into saved time, as well as things you can't kind of measure, things like personnel and wasted other supplies. And we've calculated that you can improve throughput, which is the number of patients you see per unit time, which can result in about a $45 per difficult stick savings. If you take a hospital like GW, which sees 70,000 ER patients each year, you can extrapolate that out to a net potential increase in revenue of about $800,000.
And we look at the ultrasound market, we can see that other markets that have had accessories like smartphones or laptops, when they first came out, there weren't many accessories for them. But with time, there was an exponential growth in accessories. With the ultrasound market, the ultrasound itself has had a 20% annual growth, and we expect the ultrasound accessory market, which now only has a probe cover, for us to increase exponentially just as they do. If anyone who's bought a smartphone cover, it'd be similar.
So what's our marketing plan? The key here is really raising awareness, because a lot of people are just using traditional IVs still, and we need to get them to use ultrasound. So we can do free training, and that's really our entree in. We're experts here at GW. We've trained not only our physicians, but our resident doctors, our nurses, and our ER technicians, so non-licensed providers, to use ultrasound. It's that easy to use ultrasound and place IVs. And it's reduced our central line placement, so the big catheters that go in the big veins, by 65% in non-critical patients. This was just published out of our department. So really phenomenal results that can save a lot of complications and cost. So we want to leverage the fact that quality is a big deal in healthcare, and that CMS or Medicare will no longer reimburse for inpatient complications. And we want to reach the quality people in the hospital and raise awareness so they can drive demand. We need to hit product review committees, and that comes from influencers like doctors and nurses and techs who say, hey, we use ultrasound, we need the right supplies so we can be efficient. And we can reach the product review committees by finding champions in hospitals. But we've got to create champions by training them. And then research. Well, we're at a research institution, this is what we do, and we can design research studies, use simulation to show the value of these products, and that's what also drives adoption among healthcare providers. Free training is one of those great tools that we can use, and our long-term scalability really comes from a distribution and licensing model, because we don't think that, SonoStik can be a manufacturer in the long term.
So SonoStik, we plan to drive our growth through milestones. We've already accomplished our first milestones in the first quarter. We have provisional patents filed with the Office of Technology Transfer. Brian Koblis has helped us out quite a bit with that. Everything that we have here has those provisional patents. And then we have our cores 2 through 3, prototype development, and a CEO search. We're looking for someone who has experience with startups and medical products. And then comes patent protection. We want patent next year, alpha testing and simulation, and the next clinical study and data collection, and then FDA application after that. And next will be hospitals and the rest of the world.
So the competition, there's a number of IV catheter companies that make catheters, but really our main competition is people not using ultrasound. So those are the red box, using traditional items. This is where GW is today, makeshift, right? Collecting all the stuff and then using ultrasound, which saves you some time and gives you some increase in decrease in failure rate. But you want to get to the green box, and that's where you're saving a lot of time and you're getting high success rates. The market opportunity we think is quite large. We've taken our target market as the one we know best, emergency room patients. If you funnel that down by getting rid of patients who don't need IVs and the ones who aren't difficult, you have about a 19.7 million target market. We think our kit price will start at about $42, and our revenue would come from a 10% royalty off sales. Initially, we need business plan competition money to get our prototype built and other capital for research and development. But by year 3, we hope to have licensing arrangements made with companies like SonoStik, Sonosite, or other larger companies to help distribution. We think we can have a 5% market share in year 3 and a 15% in year 5. That's domestic. Our exit is through acquisition. A number of IV catheter companies have been purchased by larger companies over the last 5 years in the $150 to $250 million range.
Currently, our company consists of Dr. Sikka and I, and we're looking for our CEO, as I discussed earlier. And we have wonderful advisors in essential areas for catheter development. We have our startup advisor, Mr. Martinez, and then we also have an FDA expert, hospital marketing expert, and materials engineer expert.
So in summary, SonoStik makes it easier to place IVs under ultrasound guidance. We have IP protection on the items we've shown you, and we have a whole pipeline of other accessories that could be of interest to develop, and we'll have to prioritize those. We've got improved patient care from our products. We save healthcare dollars. We have a large growth market that tags along the portable ultrasound market really nicely. So we think we have an opportunity for partnerships and acquisition. Thank you very much.
Okay, judges, Who wants to ask the first question?
On the regulatory side, do you see any concerns in terms of getting approvals, timing of that?
I don't think so. I mean, the catheters have been around forever. We're really making changes to the mechanism to introduce the guide wire, which should not be anything that will be a hiccup in regulatory because the parts going into the body are the same. With the coating, we will use materials that are, bio complementary, and those have been used in clinical studies before. So we don't see any major hiccups through that process.
Question?
Seems like a pretty cool idea, but it also seems kind of obvious, which is probably some of the best ideas, right? Just wondering why hasn't BD done this like 30 years ago?
One of the things. So then, when I was thinking about going through this and putting it all together, I think that we try to cope with what we have, and it's very difficult to try to change that because it's kind of like a self. You mess up, it's your fault. We take it very personally. If we don't think of changing it around, and then there are all these barriers, the FDA approval, stuff like that, to get things changed.
Also, this is kind of like, emergency physicians are kind of like MacGyver. We figure out how to make things work all the time. We struggle with that. And so that translation probably from a big company to that day-to-day use, where really emergency medicine, entrepreneurial physicians as well as creative physicians have started using this for all sorts of things. You should see the stuff we do. We're putting our iPhone to this so we can send it to the ophthalmologist so the ophthalmologist doesn't have to come in and help us out. Or we send pictures through dermatology for skin things. So I think it just hasn't permeated yet. GW is really a leader. We have a whole group of physicians who focus just on ultrasound, and we train people from around the world on how to use ultrasound at the bedside. I think we're just really an early entrant, and that can be a great advantage for us.
So you're saying the use of ultrasound to assist this is fairly new? Fairly new,
exactly. Probably, when I finished my training in 2003, we were just starting to incorporate ultrasound training into our practice, and we really weren't teaching peripheral IV placement. We were teaching things what's called the FAST exam, which is really the first utilization of portable ultrasound, using it in trauma. And then now that Adam's a few years behind me, but it's completely integrated into his training. From day one, he learns how to use the ultrasound for all these different functions. So I'm much less educated on how to use the ultrasound than he is because it's so much part of his training.
I was part of the first class that really got the training from what my attendings and bosses got us to do.
One last question.
Training could be a huge component to your revenue stream. Have you thought about, you mentioned the training would be free. Have you thought about adding a cost to the training as a source of additional capital as you start out?
We're thinking early on to make it free training that goes with it, and then having that your kits are, actually you can see it right here, that your kits are with the ultrasound, so you have it there and you train, to use it. Because we found that people who use the different devices, choosing between each one, they use what they were trained for, which is, exactly a key part of the revenue stream. So we want to train first. We were thinking free at first, but of course with time we could charge for training. We showed them the benefits of GW Hospital, and they're definite and already in the journals, so to convert that to other hospitals would definitely be important.
And especially SonoSite actually does that. The portable ultrasound people come in, they hire some of our doctors to go be consultants and train people on how to use the machine so they can drive more adoption.
Terrific. Thank you very much, guys.
Thanks.